I must say that I have the privilege of introducing our panelists, but I'm really just interested in sitting down and learning from you. So thank you so much, and welcome to McSilver. So I have the privilege of moderating our panel called The Measuring of the Impact of Family Strengthening and Prevention of Separation Interventions. And so we have three really distinguished panelists, and I'm impressed that for the panelists you kind of made their bio like this small. It's not true. And so it just hits some of the real significant accomplishments of our panelists. So first I'm going to introduce Jeannie Anand, who is the Director of Research, Evaluation, and Learning at the International Rescue Committee. She's a global leader in emergency relief and post-conflict development. She spearheads agency efforts to be evidence-based and to build an evidence base to answer critical questions for humanitarian aid and development. She's a visiting scientist at that very small place that we call the Harvard School of Public Health. And she's in the Department of Global Health and Population. You know, her research really examines the impact of programs that prevent and respond to violence against children and women across the world. And so I'm just thrilled, you know, I could go on and on about your experience, but I'm thrilled to hear your presentation. You'll see me back again as I introduce each of our presenters, and hopefully we'll have a rich discussion before lunch around some of the work that they're going to present. So Jeannie, please. Thank you.
Thank you. So I'm going to focus on, I think as the program says, parenting interventions, measuring the impact of parenting interventions in three different settings, but I'm really going to focus in the brief amount of time on both. I'll describe what those three interventions and evaluations were, but I'll focus mostly on our Thailand or the Thai-Burma border program. And I'm actually not going to focus much on the findings, even though that's my pull and what I most want to talk about. But I think one idea of this session was also to think about measurement and the issues within measurement, both in measuring the impact in these types of settings, but also on parenting interventions. And so I will draw on some of the findings, but we'll focus on what some of the issues and questions were that we struggled with, particularly in the Thailand or Thai-Burma border project, but also really across these different interventions, and hope that some of the discussion will draw out experiences that you have in thinking through and tackling some of these measurement issues. So IRC works in conflict and crisis-affected settings. One area of our focus, we work multi-sectorally, but one area of focus is child protection, which is where we do our parenting work. We both focus on keeping children in family-like settings, and as well as making sure that those family settings are supportive of children's development. And so that's where the parenting interventions come in. And so why parenting interventions? I assume this is a group that I don't need to go into this with, but as you, I'm sure all know, the science about why to invest in parenting or the caregiver-child relationship is growing rapidly. There's a deep science about how this affects the brain and cognitive development, as well as many other factors and future success. What isn't growing as rapidly is the studies about the impact of interventions in low-income settings in particular, and certainly in crisis-affected settings. And so one of the reasons IRC wanted to invest in looking at the impact of parenting interventions was to look at from the rich science that we have about the potential impact, from the rich research that we have in high-income countries that show the impact of these these parenting interventions or family interventions on children, does that translate into other settings, in low-income settings and crisis-affected settings? This, I thought, just drawing on, this was actually from some of the qualitative work with one mother that I thought illustrates the point in some ways about these settings. She said, when she was being asked about what her favorite thing about the program was, she described this activity that was done, and she said, before the house is big, and then it gets smaller and smaller, which had to do with the activity, but she said, but if the house is big, we can live as we want, but when it gets small, we have to live united as a family, which I thought was just a really powerful illustration of the experience that many of these families have in our settings of not only economically, potentially the house literally being small, but also all the issues that affect them in crisis areas, and the importance then of having united families as a buffer for children. So our questions in doing this research across 3 settings were really, one, is it feasible, are these programs feasible, acceptable in these settings? 2, does the intervention have an impact on parenting practices, on family functioning, on children's outcomes, including psychosocial well-being and resilience? And 3rd, what are the processes through which participation in intervention influences these outcomes? What are the pathways for change? So the settings where we looked in Burundi, in rural, a bit peri-urban, but mostly rural Burundi, rural Liberia, post-conflict Liberia, and the Thai-Burma border with Burmese migrants and refugees, but outside of the refugee camps in particular, so they were migrants. I'm not going to go into detail of this because it's not the focus, but I'm happy to talk more about what these interventions looked like. They did draw on different types of different programs. So in Burundi, it was almost completely locally developed, but drew on evidence-based principles. In nurturing, in Liberia, it was focused on building on nurturing parents with adaptations, and on the Thai-Burma border, it was strengthening families program with adaptations. The target population was mostly middle child, 10 to 14, slightly different ages, with a younger focus in Liberia. And then the structure and content was similar to many evidence-based parenting programs with 10 to 12 group sessions. They slightly differed. In Liberia, we did have 3 home visits. And the topics included, again, many similar to across parenting interventions: stress management, behavioral management techniques, consequences of harsh punishment. Again, the evaluation designs across all 3 were quite similar. They were randomized controlled trials with a waitlist control. So we were going to roll out in phases anyway, these programs, and instead of rolling out in a different way due to logistics or another programming decision, we randomized the rollout so that we could then use the 2nd phase of the program as the control group for the 1st phase. So that's all that shows here. And now I'll go into what a number of the questions or issues or challenges were for us around measurement. And the first is around measuring long-term outcomes. So only in the Thai-Burma project were we able to do a 6-month follow-up. In the other projects, we did a follow-up only at 1 month. And so we were able to see in the Thai-Burma project whether the outcomes were maintained at 6 months, but we still weren't able to keep the control group. And the reason for that is that we didn't feel, since we saw evidence of positive impact for the 1st phase, we didn't feel like we could wait any longer before giving the waitlist group the intervention. So the question and the challenge is, in terms of really rigorous understanding, we want to understand, do these effects last that we're seeing over time? Is it just a bump for a month or 6 months, or are these things that change the developmental trajectory of kids over time? But at least from an implementing organization's standpoint, and I'd be very interested in hearing other views on this, if we think an intervention is having a positive impact, we don't feel we can keep the control group. And so that's just a challenge, I think, for all of us to think about, is how do we understand the longer term outcomes of these impacts and do that in an ethical way. The second challenge that I wanted to talk briefly about, in a sense I'll just touch briefly on it because it's not any different from any measurement challenge on cross-cultural research, and that's just about creating and adapting measures that really work and are measuring what we want to be measuring. So these are the outcomes of interest in, they're similar across the projects, but particularly in the Thai-Burma project. And these were the measures that were used. You can see they're a mix of for example, very well used measures, the mix, the PARC, that are used across multiple countries and have been validated in these in other contexts. And then other, not the qualitative, so the Burmese family functioning scale that we developed from qualitative research. That wasn't a tool that we took from somewhere else, but actually developed it from the qualitative research. So we tried to use and draw on people's work like Paul Bolton and Judy Bass's work and Teresa Betancourt on developing locally adapted measures. We did qualitative work. We then looked at the range of measures that have been used in similar contexts. We then adapted them, used cognitive interviewing. Then where we didn't find a scale that made sense that was already validated, we used qualitative measures. So we did try to follow the process and feel fairly confident in many of our measures, although still when you look at some of the psychometrics of them, they're not really strong measures. And so the question in terms of how do we still get better at measuring some of these outcomes that are very, some of them very context specific, like family functioning, for example. The third issue is how do we adapt and test alternative forms of measurement beyond self-report? So this is findings from the caregiver report. So these are actually negative parenting, and you can see in the treatment group here, we have a greater reduction. The stars show significant reduction change from the control group. Again, negative discipline, we see a greater reduction in the treatment group. Our questions around this is how do we get better at understanding changes in behavior and particularly caregiver behavior beyond asking the caregivers themselves, did you change your behavior? We do also ask children and triangulate that information, but it is still self-report. There's a strong potential desirability bias in that, and so how do we get beyond or at least help to triangulate that? In Liberia, when we were doing Eve Puffer and Eric Green and Rhea Chase are working on this with IRC. We did a pilot where we used a dyadic parent-child interaction coding system. So it was actually, this is used a lot in parent-child interaction therapy, and it allows for coding, so it's a 5-minute tape of the actual parent-child interaction, and I haven't actually coded this, so some of you may want to describe this better than I do, but and so what we did first in the pilot was actually take just audio transcripts of a 5-minute interaction and then code the interaction that's coded on whether the parents praise or use negative statements or some other things that we know are associated with both positive parenting but also later child outcomes. The lessons from that in the pilot are the audio isn't enough, particularly in something when this hasn't been used before in that particular setting. A lot of the coding in this uses sentence structure, which is very dependent on language, right? And so now we're using in the second phase, which is a scale-up phase of this, looking to use actual video and really emphasize more the nonverbal interactions and not just the verbal interactions, which of course makes a lot of sense, but just a lesson from this work. We're also going to be piloting discrete choice options with giving parents pictures and asking the question, which one is more like you? And pictures of a parent and a child together that aren't obvious better or worse, but for example, have a child and a parent closer together in one picture and slightly more distant in another. So it's not so much a judgment question and more a which one is more like you, to try to move away from this, move away from just a self-reporting scale. So those are some things that we're trying in Liberia. Similarly, improving child measures against, so this is showing the positive parenting. This is from our child report, and we saw improvements in both positive parenting, parent-child interaction, and in parenting consistency based on the child report. And the point here is similar, but more focused on young children. How do we get better at measuring younger children's reporting across a range of measures? And I know there's certainly some good work going on around this. Fifth, just trying to think about how best to not only measure impact in these studies, but also measuring implementation variables that really matter, and also pathways to change. So going beyond, so we did look at whether the intervention was feasible and acceptable. We did a client or our participant satisfaction interview, and did a lot of qualitative interviews, and this certainly showed that parents enjoyed the interaction. They, many of them stated that the pathway was both the knowledge, they had a lot of respect for their, for the facilitator, and talked about the knowledge that they gained from it, and also controlling the mind and mindfulness, which was part, and stress was helpful for them in terms of stress reductions. Those were two that were named in the qualitative work. Will someone give me a time shout out at some point? I just don't want to get
I'll do time from here. I love
Okay. I don't have too far to go. But
7 or 8.
Oh, okay, I'm fine. 6, just want to highlight the importance of measuring unintended consequences and think about how to get better at that, because in fact they're the things that you're not thinking about necessarily. We do, in some cases, we do qualitative interviews between the baseline and the end line and try to ask those questions and then put them in our survey. In this case, we didn't put them in our survey. What we found though in the qualitative interviews is that is mostly potentially positive unintended consequences, such as parents talked about their the couple relationship improving and a reduction of violence, as well as relationships with even other family members and community members. And so we certainly can't say this had an impact across the board, but that was something that came out unsolicited from parents. And so our interest right now, because we also have a strong women's protection and empowerment team at IRC, and do interventions and research around reducing intimate partner violence. And so we're really interested in looking at how do you take the learning from intimate partner violence and from parenting interventions and think about the family as a whole and those interventions. So that's something we'll be looking at in the future. And then also looking at parenting in emergencies, in more acute emergencies than these settings were, and looking at including components of trauma recovery given the amount of stress with parents. So that's just related in terms of things we're finding from other settings as well. 7th, and I believe last, we're really interested in thinking about relative effectiveness of projects and different modalities, so the home visits, and thinking as well as other types of interventions, and thinking about both relative effectiveness, which has a stronger impact, but also relative cost effectiveness, given the places that we work in and the number of people that need support. This is really important to us. We are just starting at IRC to do to figure out across our sectors how best to do cost effectiveness analysis. And so, for example, in the Thai Burma project, we see a change in one of the indicators on positive discipline, that for $100, we see a 0.036 change on the scale. And if you look at then a 0.5 change, which is, you could argue is kind of a meaningful change on that, it would cost $1,300. But that's incredibly difficult to know what to do with that information. It's one part of a measure. There's nothing to compare it to. So my hope is that we get to, in this area of study, where education is now. So this is from JPAL's website. JPAL cannot look at, they used to, in education, a few years ago, we could only look at cost effectiveness across attendance, for example, either teacher or child attendance. We can now look at cost effectiveness on test scores, right? So we're getting more, and this list goes way down, I just went off the slide. So you can look at everything from cash transfers to scholarships to textbooks, and look at not only what the impact was, but what the cost effectiveness of that was. And I think, again, it's hard to focus, given the needs, certainly of children and families, on cost as a primary issue, and yet it's something we have to think about, especially as we go to scale in some of these projects. So my hope is that we're moving towards plotting all of our projects and evaluations with cost analysis that's really clear so that we can better inform decision makers about how to direct their programs and funding. So I'll stop there with a thank you certainly to the families that we worked with. Huge thank you to USAID who DCOF funded 2 of these projects, and I'll just stop there. Thanks.
Thank you. I'd like to introduce our second panelist. And so Dr. Deborah Darrow is here from the University of California, Berkeley, and has played a key role in the development and assessment of evidence-based home visitation programs and worked with federal administrations and those congressional leaders in crafting guidelines for federal maternal, infant, and early childhood program that was passed as part of the Affordable Care Act of 2010. She's considered one of the national experts in the area of child abuse prevention policy, and most recently served on the Institute of Medicine's Committee on Child Maltreatment Research, Policy, and Practice for the next decade. Her most recent work focuses on developing reform strategies that embed individualized targeted prevention efforts with more universal approaches to alter normative standards and community context. She's received a number of awards, very prestigious, served as presidents, and just has a lot of fantastic things to say. So Dr. Darrow, please join us.
Thank you.
Thank you.
Thanks so much. Jeannie's talk was great, and I have just a lot of, she's underscoring a lot of the challenges we see in the way we evaluate programs here in the U.S. A lot of what I'm going to talk about are the data and challenges we're facing in assessing family support and home visitation programs here in the United States. Regrettably, I don't do much work in other countries, so I hope you'll bear with me. But I do think there's some commonalities and some learning experiences across both. The points I want to really focus on today is I think we have made some significant progress in understanding how we can improve the outcomes for kids by starting early. We have strategies that work. We have components of strategies that work. What's a little more challenging here is that most of it, when we talk about evidence-based practices, are based on what you call efficacy studies, not effectiveness studies. So they're randomized controlled trials to show there's impact. Very little information on how do you make this program work in diverse communities under diverse settings for diverse populations. And because of that, we have real trouble taking these programs to scale and replicating them with the fidelity we know they need to have in order to sustain outcomes. And that if we really want to get better, we need to start thinking not so much about program models, but the context in which these models operate. So let's talk a little bit about promising interventions. Jeannie put up the brain. It's exactly the same thing. Start early. And why do we start early? Because we want kids to arrive at school ready to learn. We want them to succeed in school so they can be employed, have economic stability, and become well-adjusted adults moving forward. I think we enhance child well-being in 2 ways. One, by looking at individual interventions, which are targeted usually to parents or caretakers, as well as some kind of contextual change so that it's easier for parents to do the right thing with their children. And what do we want the parental capacity to do? We want to keep kids safe. We want to encourage their positive attachment relationships. We want them to know they're not in this alone. They really connect with other people. And then finally, to support their healthy physical and cognitive and emotional development. So the Institute of Medicine report that Mary mentioned, we looked at intervention findings across the United States, and we looked both at treatment and prevention programs. Oops, oh, I did a very bad thing. Oh, there it is. There it is. So what did we learn about these intervention and treatment programs? Well, on the treatment end, there's been a great deal of work done. When I started in this field, a lot of treatment programs, particularly around families that were maltreating, we put the parents in one room, we put the kids in the other room, and somehow we thought they would get together at some point. We increasingly now really focus on strengthening that relationship in parenting programs. The parent and the child are there together. It's parent-child interaction therapy, a lot of the kinds of things where you're trying to understand what's going on, and most importantly, what's the impact of trauma. We worry a lot less about abuse per se. We look at what's going on with that child, regardless of what trauma got them there. And we really focus on identifying what that child's needs, individualizing the program, and then working with the parents to help support the child. On the prevention end of the continuum, we have a number of models that have worked, not just the parenting programs that I'm going to spend a little more time on, but really public awareness campaigns, professional practice reforms, early home visitation. There is a sense that I think we can prevent negative outcomes for children. We can when not only can we prevent the negative, we can promote the positive. We can really have children that do arrive at school ready to learn, children that don't experience severe trauma during their early years. I want to talk a bit about the elements that have been found, and the methodology used to do a lot of these are meta-analysis. You look at a ton of studies, you see where the findings are. There's a lot of problems with these studies because sometimes certain kinds of programs are more likely to get more rigorous evaluation. And so we tend to say those programs are better, but it's in part because we haven't looked at the full range of programs as carefully as we should. But setting that issue aside, programs that seem to have the biggest effect, and I think this could happen at any level, not just highly sophisticated programs, but a basic, if you go about thinking about what do you want to do to improve outcomes for kids by working with their parents, first and foremost, theoretical integrity and being focused on the outcomes you want to achieve. In other words, you're intentional about how you structure your program based on how you think parents and children develop. You want to focus on interventions that start early. I am a preventionist. I do think not all programs have to be in the first few years of life, but they need to start before the trauma's surfaced. If it's adolescence, you need to start working early with adolescents before their problems are seen as those children who are causing all the harm. That whatever it is, whatever problem you want to stop, you go up the food chain and find those indicators that you know you can impact. Employing persistent and respectful outreach. I think increasingly we see in programs, we do struggle to get families that are most resistant. Families that for whatever reason have had bad experiences, families that have a little more trauma than most, families that are really uncertain about why you're there so-called to help them. We need to be respectful of them and really reach out in a thoughtful way. I think there has to be a systematic assessment of needs. We can't go in with the notion that we know what that family needs. This family, not all families, but this particular family, we've already decided what they need. There has to be some assessment period. And then finally, we need to have, provide, every program needs to link families up with other resources that are in their community. We need an effective workforce. And again, when the data looks at what makes for people that do this work well, no surprise, they're people that bring added value to the work. It's not that they just do what they're supposed to do or told to do or instructed to do. They are understanding why they're doing the work, and they make adjustments that are appropriate. They're curious about doing better. They are really relationship builders. So many of the families that I've seen programs work with over the years, these are individuals that really, no one's ever invested time in them. So it's very hard for them to invest time and relationships in their children. So building those relationships, a worker that understands most of this work is done one-on-one, people to people. And then the concept of cultural humility. The workers go in, again, with the notion of what can this family teach me as much as what can I do to offer them. So what about home visiting? That's the thing that everyone is just wild about in this country. I mean, somehow, I know we don't like silver bullets, but brother, everybody you turn around and think, this is it, this is gonna solve it. We have found it, we've reached the pinnacle. And why do we like it? In this country, it was a host of political issues, which I won't go into, but people really, it was this sense of the practitioners thought doing early intervention home visiting would work. The researchers were finding some evidence that was effective, and policymakers thought, hey, not a bad idea, maybe we should try it. And at that point, there was a tremendous amount of investment in this program. We think that it's a good way to reach most challenged families because you're taking the service to them in the most basic level. You're doing it in the participant's home. You're shaping the service content to fit what the family needs, not a preconceived classroom-based notion of what you think they need. You can go into the home and look at extended caregivers and the environment in which the child is being reared. And I think you can really model relationship building within a home-based context. All of those suggest we're going to reach higher risk families, and if we get them in, we can indeed do better. The legislation that sort of highlights this in the United States is, as Mary mentioned, the Maternal, Infant, and Early Care Home Visitation Program was included in the Affordable Care Act, provides assistance to all states, to not only implement home-based programs, but also to begin to build this comprehensive early learning system. This comprehensive early learning system sometimes gets lost in our rush to replicate programs, But in essence, that's what the magic was about this. It wasn't that home visiting was the only thing we would do. It would be leverage to begin to think about what are the contextual issues we need to hit. It's a huge investment. It has been extended for one additional year, so it's probably up to about $2 billion by the time the legislation runs out. It is up for reauthorization, and in March we'll know whether it's going to continue or come to a screeching halt. The legislation is built around a set of core benchmark areas. And this is, I think, one of the principles that we really want to build into any of the work that we do in terms of measurement, that there has to be some agreement on what you're trying to accomplish. Knowing that people may interpret these slightly differently, knowing that not everyone will do all of them, but there's a consensus that these programs, as designed, want to improve maternal and newborn health. They want to reduce child injury, child abuse, neglect, and emergency hospital visits as an indicator of those problems. Want to get kids to school ready to learn, wants to address crime and domestic violence, wants to have the family to be economic self-sufficient, and then they want to do a lot of coordination and capacity building. All the programs that are implemented under this have to pick some of these objectives and work towards them. When they were deciding what programs were approved, what model programs would fit the bill, there was a sense of what we meant by quality research. And so the research that was counted, as I said earlier, was not about implementation research. It really was about impact outcome research. Randomized controlled trials were more highly rated. The measures that people felt really counted were direct observation, direct assessment, administrative records, and self-reports if they used a standardized measure, not parent saying, I think this is okay. They really set a bar. They wanted to look at impacts for at least 1 year. They wanted to see the findings replicated. They wanted to have a minimal of unfavorable findings. And I have to tell you, when you look at all the research on these programs, every model, and I mean every model, has probably far more no impact findings than they have impact findings. That for the most part, when you look at 1 million measures, you're not hitting the mark all the time. You're hitting on a relatively small percentage of them. And the programs that were picked were the programs that had a few more positives than some of the others. But it was far from universal. Evaluator independence is considered important, and then the effect sizes that people talk about it. They wanted moderate to large effects. These were some of the models that were picked. Some of them are well known in this country. Some are maybe a little less well known, but they range. Some are multi-year efforts with families, which are the top 4 on here. They provide home visiting services to newborns and their parents, pregnant women, and their families for 18 months to 2 years or longer. Some of the ones on the bottom are smaller. They go for a shorter period of time. They focus on a slightly broader population. So what are the findings from all of this when all is said and done? I like to think of findings on parent-child factors and community system factors. And here you can see that I think we see a constellation of improvement on knowledge of child development, reduction in parent stress, improvement in parenting skills and parental capacity, some addressing of maternal depression, positive child development indicators. On the community side, they are linking families up with services that are existing in the community. So in other words, home visiting carries its own portfolio of improving families, parenting capacity, and then this linking, this gateway to other services in the community, both of which are extraordinarily important. What we're a little less good at doing with home visiting is we don't really work with serious mental health issues, substance abuse, domestic violence, and I'll talk in a minute about why that's the case. And then this really notion of if you wanted to change community and system, you'd want to be changing normative standards regarding parenting. You'd want to be looking at service quality, not just getting people to programs, but actually saying to yourself, are these high quality programs? How are we going to change them? How are we going to address those shortcomings in the healthcare system, in the child welfare system, in the education system, so that when kids finish these programs, there's some place that's going to pick them up further down the line and continue to reinforce these notions. So what accounts for the inconsistent outcomes? And I think you heard it a little bit this morning when we were talking about it's not all about being an orphan or a half orphan. Fred and I were chortling to ourselves. Chapin Hall actually started as a half orphan asylum. That's what they called it. And half orphans were ones that still had one parent living. That was the term they used at the turn of the last century. It doesn't work for everybody. And it's figuring out what works for whom under what circumstances. The home visiting models as currently designed are not as good as they need to be in attracting, I think, those families that are most challenged. And even if they bring them in, they don't keep them long enough to maximize the gains they might achieve. I think some of the skills and the techniques that families that are really challenged need, the current home visiting curriculum and staff training capabilities may not be there to fully address those families, and that's another reason we may be falling behind. And then I think most importantly is there is this absence of reliable and robust implementation data, effectiveness research, to show how we can do this. And in fact, the lack of that kind of data was one of the major conclusions from the Iowan report. If we had to put our eggs in one basket, it wasn't that we would say, go out and do a lot more studies, outcome studies, to figure out what's the marginal benefit of doing this program versus that program. It was saying to yourself, how do you take programs that work and be able to disseminate them and take them up to scale and then sustain them over time? That's the research base that is very thin. And if we don't develop it, I think we'll always be in this cycle of coming up with the new silver bullet, the new bright idea, because we're not fully investing in some of the good ideas we already have. Secondly, I think we've come to know that it's not just about the model, it's about the infrastructure that surrounds the model. So it's a competent workforce, it's a good data system, it's fostering some kind of system integration so that no program is out there by itself. So if I was doing these robust operating systems, what would they look like? Well, first I'd start with an evidence-based model, because I think that's important. You have to have a brick to build a house, or some reasonable facsimile of what the brick is. Then I believe in some kind of universal assessment. What you asked about, what are the high risk? And my sense is the more we try to find the ones with the problem, so that's the only ones we serve, the further we are from reaching them. That at some point you need to say to yourself, healthy child development is important for everybody. We need a universal way to assess that, because I can't tell by looking at you whether you're a good parent, a bad parent, a challenged parent, a skilled parent. I can only do that if I ask you some questions. So for any effective system for an evidence-based model, you have to have some kind of universal outreach and ask, just as we have universal education in this country. You know, we don't send kids to school because we know how to educate them, although many people think we do. But we actually don't. We do it because we think it's the right thing to do. We do it because every day we want to get better at it. That same notion really has to begin to apply to early childhood for these programs to be most effective. Once you have that, then I think you build this service linkage and referral systems. You really reach out. So you have the program, you have a sense of universal need, then you're lining people up with the level of service they most need. And then finally, the normative context, changing the values that people have about kids. And that unless those all work together, I'm not certain we can get what we want in terms of sustained outcomes over time. I think there is one. I wanted to end with some of the things that I think McVie is doing well, because we hear a lot of things, the federal government's doing poorly. So on a positive note, I think these common outcomes and set of performance indicators has been very important in advancing the field. It's really focused people in on, you need to do certain things and you need to do them well and you need to do them consistently. I think focusing on interagency collaboration. No, this isn't a program that the health department owns, although sometimes they think they do. They do not. But it's really a partnership between child welfare, public welfare, human services, and public health. The place-based focus of this initiative, it asks communities to pick communities that seem to be facing some of the deepest challenges and to try to provide some sort of depth of coverage to all the families living in those communities. I think that's a really important thing to come back to. If you can't do everything in a country, are there communities or sections of a country that you could really drill down on and provide greater coverage, greater penetration than trying to do a little bit for everybody? The idea of using local services and supports, not just the new program on the block, but how does this new program leverage the effectiveness of the services that you have around? And then finally, just an ongoing commitment to using data. It came up in the earlier talk, and Fred will probably say this later, but I'll steal his line. We have a lot more data. It's not that we need more data, we need to learn how to use the data we have. And that's probably the greatest imperative. And that's it. Thanks.
Thanks. So, Dr. Andrew Maruki.
Maruki, yes.
See, easy for him. and so our presenter today has a PhD in social work from the University of Missouri at Columbia, and did a fellowship, a postdoctoral fellowship at the University of Wisconsin-Milwaukee Center for Addictions and Behavioral Health Services Research. He's worked with Save the Children, USA, and University of Wisconsin-Madison to evaluate the impact of community-based approaches on OVC care. Current research includes looking at the impact of community caregiver, parasocial and health workers on children's care, and gaps in access to services for the girl child across the world. And so I'm just delighted that you're going to talk to us today, and then I look forward to questions and discussions as we go. Thank you.
Thank you very much. It's more of a continuation, even though she says she only focuses on US. It's more of, how can I say, another example of home care, home visitation, but in this case, using the community caregivers. In other words, using community caregivers to provide care, to provide access to vulnerable children in Côte d'Ivoire. I was brought in by Save the Children to do an independent evaluation of the programs, and I would like to, as when we talk about data, to encourage everyone also to continuously use administrative data that a lot of these programs have created, because they are rich in the information that provided in terms of the care and type of access they have provided. This research I did in collaboration with a colleague in Côte d'Ivoire, Samuel Ado, at the National Institute of Public Health, and in collaboration with Save the Children, because we wanted to see what type of impact the program they had for OVC, and they were using community caregivers. We used administrative data, and then we did a review of 700 OVCs. It was funded by USAID, Save the Children, and Wellspring Foundation. Background, as I said, in the other presentation, we're looking at multiple programs or multiple studies. I'm looking at just one. And the reason why we're looking at one, I think it's powerful in terms of how effective when community, especially individuals that are attached to the community, provide care, because they can have a very powerful impact with the population that we're interested in. Community caregivers in Côte d'Ivoire are provided in the forefront, and they support the vulnerable left by HIV and other issues that create the vulnerability. The one in they identify care, and do the home visits. They provide emotional, psychological, and practical support. They get training from Save the Children and the NGOs that they work with, because the way they are not directly under Save the Children, but under the NGOs that work within the communities. And one of the current challenges in terms of part of this study was to see how effective are they within the community too, because of issue of the way structurally they're kind of like an invisible workforce. They're there, unrecognized, unregulated, but how do we be able to advocate for their case? And I believe if you look at the literature, you find is in other countries it's nearly the same type of narrative, where you're finding a group of individuals that are working hard within the community, but they don't get the recognition and the remuneration that they get. They collect a lot of the data, which is also used by both national and international policymakers. So the objective of the study was to investigate the impact access to healthcare and social service for the vulnerable children in Côte d'Ivoire by looking at the activities they provide and the impact of those clinical and social outcomes, and to understand what barriers the CCs, the community caregivers, were having when provide that particular care. We use kind of a mixed method study because we wanted to not only to look at, in larger case, how all the vulnerable care, how the systems were providing the care, but also to look at create a quite experimental where there were some programs in Cote d'Ivoire that were not using CC model to Save the Children, and that was good for us because it allowed us to compare what's the difference. Where you don't have to withhold care, there is already another program which is providing that those services, but not using the model that with CCs, and was to see, okay, are there some issues? We selected 175 CCs within 13 NGOs. The control groups were children within, similar to the who had access to CCs, but living within the same area, so that we wanted to be able to do that comparison. And the data was, the sample for the control was a little bit smaller, always a little bit challenged to get people to cooperate to show differences with it, and especially when you're looking at, we're sampling I believe 5 regions within the whole country. But the proportions were, in terms of control, were a little bit better, but within the intervention, we had more female than males. The results were, how can you say, a huge difference. In other words, when you look at the care they received, there was no comparison in terms of the children who had CCs. The children with CCs had, when you're looking at number of services, let's say for example, 70%, about 70% were receiving 5 to 8. Let me if you look at this graph, when you're looking at this number of services for each child receiving, for the CCs, had a higher number, having a higher set of services that access all receiving services, but looking at those ones without CCs, you have more not receiving or having 1 or 2. So the challenge is that the CCs, to some extent, are not only just an advocate, but provide a lot of that linkage where we talk about the elders in the particular child's life, and they have an impact in terms of accessing nutritional nutrition and food. Because not only did we get the kit, we also looked at did they improve when you're looking at the weight, even if you're looking at the development. Because with looking at because the CC also provided nutrition information, not only just the food preparation. CCs also sometimes worked within the household and made the food for the children, for those ones who had. So the CC had a big impact on the children's life. So when you're looking at the outcomes, you start seeing a huge difference. Access to getting psychological support in terms of joining groups so that they can get emotional support. CC had a very huge impact. Economic strengthening. And when you're looking at information about adherence to the drug, adherence to treatment, access to testing, there was also a huge difference when you're looking at the clinical care. So even though when we look at the lives of the community caregivers, they might not have, when you're talking about them as parasocial workers, they might not have the educational background as some within expect, but they had a huge impact because of the way they were communicating, they were engaging within those particular households. So the limitations were limitations in some regions. Recruiting was a challenge because of some of the transit nature of the overseas, especially within larger areas. And in some, because of the age, the respondents were caregivers instead of part of it. Some NGOs were not part of it, and were not so willing to be participants, even though we didn't want to be compared. So part of it is we felt that CCs and as a model in terms of providing care for vulnerable children is one I think can have a huge difference in terms of a huge impact on providing better care. When I was talking about the food, and part of the ways we were able to capture and see was there a difference was that they had better medical records, so we were able to look at after receiving nutrition, they gain weight and what type of weight, and was it significant? So they had better records, so it was easier to also see, okay, was there an impact by having these under CC within their lives? There are significant barriers, obviously, to CC income, and part of it is because they're also considered part-time, and it's more of an issue of how they are recruited. Also, there's the inconsistent application of standards within the CCs, how you're recruited within regions and NGOs. That hopefully, when you standardize, will help that in terms of encouraging. And part of the other challenge we also found within the study was the families still had issues of stigma. In other words, having a CC visit you also indicated that you had problems in your household, and there's this issue. So that created almost like a resistance to having CCs within their, and others felt that just having somebody inside your house also exposed to some of the issues within the household. So you have got the issue of the stigma, and also you've got household felt privacy they needed to control. So part of I think the study was we just felt that CCs should be part of. Is an excellent model in terms of presenting that, especially when they're looking at vulnerable children, and especially in low-income countries like Cote d'Ivoire, where they had a huge impact in the outcome. Even some NGOs lack adequate resources, so better support of NGOs to provide a standardized structure would help. Training, evaluation, methods of also recruiting, because recruiting, once you standardize, also recruit better quality community caregivers, and they help in terms of not only collecting the data, because it also increases the reliability of the data they collect and in the way they report. And I think, to me, that can in the long run will help. So, particular study, I know she was looking at a macro. We look at from the outside, and we felt that CC had a huge impact, and programs that really, especially national programs with resource poor countries, they can benefit from this particular model. Any questions? Thank you.
I wonder if I could ask also some questions for our colleagues. Always stand in the way of lunch. There's one. Very good.
I'm particularly struck listening to your presentations with the evidence aspect, because it's something that that I know researchers are struggling with. In particular, I think Deborah, you pointed out this issue of what is the best evidence base. It's the one that gets the RCT, and therefore, if you've got an RCT, it's more likely to rise to the top. But then we also heard from Jeannie and Andrew the reality of using other methodologies. And I'm particularly struck as this in terms of, Jeannie mentioned not being able to continue with the control group. When you're operating in a country where you're testing an intervention and there are no other, and Andrew pointed out, actually there was other in this case, but there are no very limited other services. How do you test? How do you actually get the level of evidence that will pass,
Well, I think having some kind of counterfactual is just important, because even if you see change in the program you're working on, you don't know if that change would have occurred in the absence. So what I loved what you did was you found a counterfactual. You found something to do. Another option is if if you have data on the population overall, and there's some way you can look at how families with the characteristics that you're working with hold up against this larger data set, and you all talked about population level data sets. You can use that to begin to tease out what you're doing. But to me, it's a process of repetition. You collect data, you learn from it, you collect a little bit more data, and then staying within what you're learning as opposed to overclaiming what you can do.
I think that's a great answer. I don't have much time, just to say, I think the emphasis on the counterfactual, and I do think even in the most, I mean, we're actually looking at how we can ethically, and I think that's really the central piece, but look at a counterfactual even in acute emergencies, because it's just so critical that these models or assumptions that, when tested, a number of them don't stand up, that we continue to look at and don't just sort of, and I mean this is a community, no individuals, but make excuses that this is hard and so we can't do it. And I think we're trying to say it's incredibly hard, but we have to do this in order to make our programs better. And so, whether it's finding a comparison group, matching, we just did a study in Lebanon on cash, which wasn't, it was just general impact of cash, not on children. But we used the cutoff of 500 meters. That was a programming cutoff. We actually did it after the study, and used a regression discontinuity design to look just above and just below the 500 meter line. So it didn't have to meet with anything, there didn't have to be any, but we were able to construct a control group. And I think just being creative and pushing, and this is where I think academics and practitioners can come together and really think about how do we take what we know about methods, we don't have to create new things, but how can we stretch our minds and practice to just push a bit further and not let ourselves off the hook because of these difficult issues.
Please. I was just at the Global Reduction of Violence meeting in Cambridge,
yeah.
and IRC was there and presented Amanda Sims also some of the work. And what was fascinating was they had people from the women's violence community as well as his parenting program was, as you said, the parenting program is showing an impact on relationships between partners. But likewise, Charlotte Watts from the London School of Hygiene and Tropical Medicine was talking about how their interventions on domestic violence are showing improved parenting outcomes. And one of the points, and I'm just wondering with the evidence, we often talk about models. So you talk about the CC model in Ivory Coast being very similar to the home visitation, and I'm sure some of the parenting has these elements. And are people pulling out those components that actually are shared across the intervention as opposed to the model, and evaluating and trying to pull out what actually is effective in terms of focusing on healthy relationships that have impact on outcomes, as opposed to just evaluating the model? And is there that sort of questioning across different interventions?
Well, I hope so, because I think the challenge is that sometimes we focus on terminology as opposed to the way the implementation of those models are. And sometimes if we strip away the terminology, we find similarities, and that similarities can help in terms of being able to compare and look at built-up evidence.
And I'll tell you, maybe I've been in this field too long, but I remember a time where people just talked about components. And then everyone said, but it's the synergy across components, and you have to look at how they work together with each other, and that gave birth to models. And now we're saying, hey, the model is too big, let's take it apart and look at the components.
Something in between.
Yeah, there is something between. The first two slides I showed really are the results. Rick Barth did a wonderful component analysis on parenting programs. CDC did a similar analysis on parenting programs. A lot of people are trying to do it in home visiting. But part of the issue is programs that have certain characteristics are more likely to have these randomized trials. And when you do these kinds of meta-analyses, those studies are weighted higher. So the characteristics of those programs seem to pop up in this analysis. I think it's really difficult when you start taking it apart beyond the few components that I've listed. But I agree with you. Many of these models have much more in common than they have unique, and it's the idea of selling a brand. I think Rick has used the term the difference between commodities and products. where, you know, maybe we should be thinking about this as a commodity, not as a brand identity product. Because they'd probably reduce the cost if they were generic. Yeah.
We haven't done components in and I don't know it being done in international work, but I certainly know the discussion. But in mental health, this is also an issue, right? I mean, if you look across mental health interventions, the overlap is incredible. And so what we did with Laura Murray and Paul Bolton and Judy Bass in one of our projects looking at mental health care for children, particularly, well, it started as a focus with for child survivors of sexual violence, but then quickly moved, given how hidden that is, to just broadly children who are either showing internalizing or externalizing behavior. And we thought we were going to do trauma-focused cognitive behavioral therapy, since that's a well-known model, an evidence-based model. And then it quickly became clear that, and a push from Laura Murray, which is great, to say, why don't we do it more of a components-based model, because these kids are actually, they have no other services, and we're seeing a range of services. So if we can, let's try to do a training where with diagnosis we can pull in the different components so people can choose and use what's most appropriate and serve the widest range of children. So we only did feasibility. I mean, it was incredibly challenging given the two places we did it, to even do the model, to have children to see. But I, in terms of feasibility and acceptability, it seemed to work quite well. Lay people without any kind of mental health training were able to conduct it and use it. And it certainly allowed us to hit on a much wider range of problems than it would have with just one particular model that we went in and seeing. So I'm really excited about exploring that more and testing it, and certainly think for the parenting it would make sense as well.
I'm sorry if this was asked when I stepped out, but I'm a little curious on this community caregiver model, what the control group was. You said there were programs that didn't use the community caregiver model.
Yeah, there were actually other overseas programs in Cote d'Ivoire, but instead of using care, because Save the Children used the caregiver model in delivering services and making sure that they had access, not just deliver, because the caregiver don't actually deliver, they made sure that the overseas had access to those services and encourage them. And but in some of them, when we did the review, was that they also engaged in terms of when, let's say, for example, if the child wanted, they cooked sometimes food for the children, they went and bought food, or they encouraged them took them to medical facilities when they all made appointments. So in other words, almost like became a surrogate parent to some extent, and and that attachment and trust has allowed them to go further in being able to have those children not only get care but also nourish and thrive within the program.
I got that.
Yeah,
what were you comparing to?
But to similar programs overseas, I mean, where they didn't use, in other words, were Save the Children programs. So they were not within the same. There were other programs within Cote d'Ivoire that were delivering care to the variety of children, but they didn't use the CC model.
So what model did they choose?
They were just had access to they recruited the obviously to the program and allowed them to have the access to the programs they had. The same services, in other words, looking at nutrition, looking psychology. So all were available, but there were no CC who were basically engaged with the children.
So it might be more like a center or an association that just didn't have this outreach arm.
That's an interesting interpretation, because then it's a question of, it's not just providing services or resources in a community, but someone needs to be the navigator.
Right.
And that was a very effective navigator program.
Can the moderator ask a question too? Okay. Yeah. I have the real privilege of doing both local kind of U.S. based research as well as global work, And a lot of our US-based research has influenced what we've done in HIV prevention and care. But in my global work, these carers, community carers, parents, community members, lay resources are very common in my global work. And then I try to bring that work back to parenting interventions, to child welfare, safety interventions, and the pushback I get from both model developers and scientists and system leaders is pretty serious. And yet I think, Deborah, you did a really good job identifying there's a portion of families that our currently existing systems and models are not reaching. So could you offer some help about how we might be able to draw on what we're learning globally into kind of more our local work?
You know, we're such a professionalized, specialized society.
Yeah.
And just because people, professionalism in my mind is partly consistency. It's that you can count on this person to do something in a competent, consistent manner. And if we could think about that as opposed to having a specific degree.
Yes.
So that's one thing. The other is also knowing when there's limits to what someone without the degree can do, and making them comfortable referring families or bringing in someone with a higher skill set. That's really, to me, the tension. That for many families, they're befuddled by the system they find themselves in. They don't know where to get help. They don't know where to go to. They don't know what's normative, what's not normative, and the community worker can help resolve that. But then there may be some serious issues, and that's when you need to be able to handle that off. And I think that the most effective prevention program, I shouldn't say that, there's one model that feels strongly about professionals, but some of them really have this sense of partnership, that it's really a professional along with the community worker. Because from a cost perspective, it really does bring down the cost of this program tremendously.
That's really helpful.
And I'll just add, I'm really excited that you asked that question. I mean, I may get my psychology license revoked for saying this, but I mean, I think a huge part of this is the gatekeeping of professions that, I mean, we again saw enormous impacts of a cognitive processing therapy done by women in Eastern Congo who most of them didn't have a high school education. Enormous effects.
Right.
And I think there is no reason that we can't be seeing that in this country. And I'm not suggesting, that there's nothing to professionalism in a degree, but I do think looking at task shifting and its effectiveness, exactly as you said, what people can do, and then when to refer for services and what's appropriate at what level, so that we can reach more people here, I think is, and I don't do any research here, but this is exciting.
For me, I think it's an issue of trust, because when you're talking about this, it's the trust relationships which are created. Even though we're talking about it, she said professionalism, but it's also the trust systems that are created, and it doesn't. And when you can have a community person that provides that trust,
That's right.
It helps in lowering the barriers
That's right.
in access to whatever services you're trying to provide.
Sorry, this is a follow-on. I find this fascinating, obviously. First of all, were you all in the programs that you look at and measure, what are the trust measures? Because are you asking people, do you trust this community caregiver? Do you trust this parenting intervention specialist, whoever they are, and how do you measure that? Because I agree that it's absolutely crucial. And my second question with Jeannie, you touched on audio's not enough. What do we know from some of these other interventions about video or other forms of measurement that we can use across context? And just an anecdote before I turn it over to you. There's this fascinating program in Newark where a healthcare reform program is seeking to get at the most costly 1% of healthcare users, which are people with extreme problems that are frequently in the emergency room, et cetera, et cetera. And it's a very sophisticated outreach model where these people are getting lots and lots of visits, and it's showing promise, but what they're having to do is to restructure the requirements for the people who undertake this work, and they are not MSWs. Love social workers, though I do, I love you all. But they are people who have trust in their communities. And how do we get at that and get around this licensing, credentialing issue that we face?
Well, in our study, we had a question which looked at if they were satisfied in terms of with the caregiver, within the ones in the CC. Over, I think 90% said yes, and it also depends because of when you're looking at the interaction and looking at, but a huge number. But you also look at the way they had engaged. If you look at all the other factors where you're looking at what the variety of activities. So you find that to some extent the CCs had become part of almost like their family. And to me, that was kind of high number at first. I was saying so I reviewed some because there's a couple of other measures which looks at whether they wanted and looking at the different aspect, whether the type of services, but you find a very high satisfaction rate. And then if you look at those non-CCs, if they would want, I think over 90%, 97% wanted to have a CC in their lives because they're seeing how the others are being treated. So you're finding that there is I think a huge trust issue when they were able to engage with the CCs.
Yeah, we
relationships already right there in their communities. They have which might be different than the U.S. model potentially.
we as part of our evidence-based home visitation evaluation we just completed for ACF, we used the working alliance inventory, helping relationship inventory, same concept. And we did find that the provider and the participant liked each other, trusted each other, believed that each other was looking out. There was not there wasn't a trust problem. What we saw though is when it came time to begin to try to move the family to a different set of behaviors or some sort of change, that's where the agreement and the relationship started to look a little less positive. So in my mind, it's that the home visitor and the provider, the home visitor and the participant like each other, respect each other, there is a sense of bond. But getting people to change and to adapt what you want, and I'm not talking about change that's inappropriate, but change in a way that would nurture the healthy development of the child, then trust may not be enough. There's something else. We weren't able to figure out what the something else is. It's a little bit more than that. And the issue about videos and use of that, a lot of the programs are using this observational videotaping both as a supervisory tool for the home visitor and as a teaching tool with the parent. So when you do the video interaction between the parent and child, then you come back and you slow the video interaction down, and if there is every positive thing the parent did, you focus on it and you say, brother, did you see when you did this? Did you see what your baby did? Mary Dozier does it in her ABC program, In the Moment, where you're constantly observing the parent-child interaction, and every time something is done right, you just really drive home to the parent, this is great, this is great. And she's having terrific results with that. So that reinforcement, that feedback loop, that because too often these are individuals that are told what they're not doing right, kind of all the time. So to be able to pull out and lift up what you are doing right, it's a great teaching opportunity. And training workers home visitors to be able to do that.
I mean, hearing you describe that, this is going to sound very stupid, but it reminds me of the television show Super Nanny or whatever it is. And this is very much what she does, is she records her the parents' interactions with their children. I love that show.
Well, with that, I think if you join me in thanking our panelists, I think somebody can give direction.